Well, ladies and gentlemen, thank you for being the most important people in the room, ultimately. We're here to obviously illuminate health equity, social determinants of health, but I would be doing us all an injustice if I didn't introduce these two wonderful people with me. John Hoffman spent 37 years with Johnson & Johnson in varying roles, from finance to marketing to running patient assistance programs, and his most recent role was leading the advocacy and policy team at Johnson & Johnson, where he was able to help instill their health equity focus as an organization, and truly, based off of data that I run, lead that for about 10 years as the #1 patient advocacy-focused organization in healthcare. Austin Williams has been working to drive community-based engagement for a very long time. For over 20 years. She's got an amazing background, including being the first African-American winner of Miss America in 2014. Her work as the crown holder included ensuring in fighting child trafficking as far back as 2014. So some amazing work there, and she continues community engagement and helping patients and the general community through the Medi and the Medi.org, ensuring that we all can come alongside patients to provide the support that they need, whatever stage of life they may be in, and truly trying to rebuild a community-based approach to healthcare. So I applaud them and thank you for being part of our discussion here. Just so everyone has a sense for where we're going and what we're really all about. One of the big issues that we identified within the healthcare sector was, what is health equity? What are the social determinants of health that we should be focused on? So we want to level set and provide some definitions for everyone to think about, take back to your organizations, and identify ways we may be able to aid these patients outside of just patient assistance. We want to understand what the key elements are of social determinants of health that are having an impact on the patient community, shine a light on some of the current work that's being done to address health equity and social determinants of health, because it is being done. We are seeing that from the voice of patient advocates, professional societies, and community-based organizations, and provide a case study on how you can take some of these key ideas and topics, bring them back to your organization, and hopefully, similar to John, make them a capability within your organization, not just a nice to have. So we'll tee it up. John, for you to introduce us to some of the key definitions as we think about social determinants of health, health equity.
Yeah, thanks, Matt. Hello, everyone. Yeah, as Matt said, I had the privilege of starting the initiative, which became a capability at Janssen to address health disparities. And one of the first things we had to do was get everybody on the same page as to what the terms meant. They were being inappropriately used, they were being used interchangeably. First of all, everybody thought, well, we have a DE&I program, a diversity, equity, and inclusion. That's internal. That we're talking about the external environment. And it starts with health disparities are the differences that exist in outcomes in different populations, whether in whatever disease state. Health disparities are caused by the social determinants of health, and we'll talk more about them. I know Austin is going to go into more of that. Health equity is basically a journey that may not ever be achieved, but is the absence of health disparities. It's the goal, the North Star through which we proceed. It's important to understand that, so get everybody on the same page and using the same terminology so that you can focus on what really needs to happen to make a meaningful and a sustainable impact.
Yep. And John, I think you would agree in adding that diversity, equity, and inclusion is not clinical trials.
No.
Right, and I know that we've seen that pivot heavy within the industry. Yes, it's important to gain inclusivity in clinical trials, but that is not the primary role of diversity within an organization. John, I know that you had also talked about how do you go about finding some of these issues and root causes?
Yeah, when we started the process 3 years ago, everybody wanted to be involved. It was great because there was this heightened awareness after George Floyd, et cetera. Better late than never. But everybody wanted to do something, and to your point, whether it was throwing money at making sure there was representation in clinical trials, et cetera, what we tried to do is take a very systematic and pragmatic approach to say, first of all, let's verify what are the key disparities in each disease state. What are the known and what are the suspected, and do research if we have to do our own research. Once we identified, you're not going to boil the ocean, figure out the 2 or 3 that you think, A, we can impact the most, and how we can have the most, can impact the most people. Then really understand what are the root causes, starting with the social determinants of health, but also looking at simple things like, are our marketing materials multicultural? Are there biases, both known and unknown, aware, conscious and unconscious of providers? Are there issues? You'll see some, later on some of the things we didn't even know. Some of them we can control as a pharmaceutical company or as other stakeholders in the process, but almost all of them require a collaboration of different stakeholders, non-traditional stakeholders working with faith-based groups, HBCUs, sports teams, et cetera, community service organizations, to put together a comprehensive approach to make a difference that, once again, is impactful and sustainable. And then implement those strategies and then disseminate. Once you figure out a test and learn process that works, you can then share that and replicate it in different areas.
Fantastic. Now, Austin, I know we talk about the term social determinants of health, and I love the way that you put it, which is the thing behind the thing. You tell us a little bit more about what that means and what social determinants of health really are.
Sure. So ultimately, we look at a disease state and we go, that's a person that has diabetes. But the thing behind the thing is actually looking more intentionally about where is the intersectionality of barriers that lead the person to have the disease state. So that's why I call it the thing behind the thing. The thing is really obvious, that person has diabetes, but the thing behind the thing is, well, what happened that got this person to the place where they then had diabetes? So I'll give you an example of what this looks like practically. Let's say Sabrina lives in a food desert. So because Sabrina lives in a food desert, Sabrina doesn't have access to healthy heart foods, foods that are going to nourish her body in a way that will help kind of remove that, the things that lead to her diabetes. And now we know, okay, she's in this food desert, but she doesn't even want to live in this food desert. And so she got herself a job across town where she was making a livable wage finally. However, her community has really limited transportation. And because she has limited transportation, and she doesn't have a car of her own, she has to take the bus to work every day. And because she has to take the bus to work every day, she gets to work late sometimes. And because she gets to work late, she got fired. Now, she doesn't have a regular paying job and a living wage. So now she lives in a food desert, and she doesn't have a job, and she doesn't have a livable wage. So now she has this apartment, but she doesn't have money to pay her electric bill. So she no longer has electricity, so her insulin is no longer refrigerated, and therefore she is not taking care of her diabetes because she has no electricity. She has no electricity because she didn't have money for the electricity bill because she didn't have a job, even though she tried to have the job. So social determinants of health are not just this is where people live, work, and play, but it's how the impact of where they live, work, and play become the barrier to healthy outcomes. So Sabrina, her barriers were transportation. Her barrier were healthy foods. Her barriers were transportation. Her barriers were living wages. And if we removed some of those barriers and addressed some of those things, that would help Sabrina have a better health outcome. That's the thing behind the thing.
Fantastic. And I know that we talk about, you've talked about some of these already with regards to economic stability, education, which we've heard in many different sessions already this morning, individual education. What does that look like? How do we individualize education? What is the health literacy level of the patients that we are trying to assist? There's a lot of elements that come through that. Anything else that you might add?
Absolutely. So my background is in community engagement. My background is not in public health. And one of the things that I see most frequently, especially now working in a public health space, is I have no idea what y'all are talking about. And so I end up going like, hey, we have to make this plain for the degular people like me, who are just out here in the street living our lives. And we don't know all of these terms. We don't understand the terminology. And one of the biggest barriers, in my view, that I see working with communities and with historically underserved populations is that they just don't know what we're talking about. And so making sure that we're making things plain, helping them even understand, like we start talking about social determinants of health, they don't know what a social determinant of health is. I remember coming into this space and being in conversations with people, and they're referring to SDOH. Well, the SDOH led to this, and I'm like Googling in the meeting, what is SDOH, right? But really, it's the thing behind the thing. And when you help even our patients understand, hey, part of your barrier is that you don't have access to healthy foods. There's not a park in your community, and that makes it harder for you to go and exercise. Hey, I get that you're having a hard time holding down a good job because of transportation. Let's try and focus on those things and then see how that impacts your health outcomes.
Fantastic. Yeah. John, anything else you would add to that?
Well, and it's not just the social things.
Yeah.
I live here in Philadelphia, and if you have someone with rheumatoid arthritis or inflammatory bowel disease, there are also infusion deserts, not just food deserts. Almost every hospital in this city is a teaching and research hospital. They are not focused on providing outpatient infusion centers. Similarly, the rheumatologist and the gastroenterologist don't necessarily want to open up practices in the city. It's expensive, or it's not the greatest neighborhood that they're comfortable doing it. So we've got to figure out one of those things, that you have their healthcare access and quality. How do we bring the healthcare to the patients rather than assuming they can get there? To Austin's great example.
Yeah.
I had one more story. I was doing some research on Black maternal health outcomes just yesterday, and I came across this fascinating study that showed that there was an association between maternal health outcomes and neighborhood violence, and specifically gestational age. So think about that as one of the things behind the things. Violence in the neighborhood led to prematurity. And then another one, that association that was fascinating, was that depression and anxiety, there was an association with preeclampsia. We don't always go, like depression and anxiety are things that will lead to preeclampsia. But these things behind the things actually have these long-term impacts and affect long-term health outcomes for people.
Yeah. It's interesting too, as we try to move patients to positive outcomes, even my own story. I broke my neck in 2005. I couldn't slouch right now if I wanted to. I'm fully cervically fixated, but it took me 20 years to figure out how to finally get off of opiates and out of pain. If it takes someone who's worked in healthcare 20 years to figure that out, and I don't necessarily have the same barriers as everyone else in the community, what's that going to take the general patient? And that's the sad reality of what we're all up against, especially as we think about, well, maybe we can help aid you financially for your product. Maybe that's not the issue. Maybe the issue is I just can't get it infused, or it's leading to something else that's leading to another problem. And we have to be able to dig deeper. Obviously, we want to make sure that at all times leading with empathy. As Austin will talk about shortly, right? Technology without people
is pointless.
Pointless, right? But we also have to change the narrative. We have to engage and want to engage, but at the same time, we have to recognize, do we have the trust? Do we have the community trust? Does the advocacy organization have the community trust? Does the community-based organization have the community trust? And perhaps we need to work 3 organizations away to get something accomplished, but we're still going to get it accomplished if we do so effectively. Some of the key areas and examples that we wanted to call out for you here in helping us to wrap our heads around, it's not just Black and brown communities. This is elderly or low income. Better yet, you have the new ALICE terminology, if you want to throw that one out.
So the ALICE population are folks who are asset limited, income constrained, and employed. So we're talking about the people who go to work. they have a job and they're still asset limited, income constrained while they're employed. They're the people who go to work and they still can't make ends meet. They are the 72% of the population, US population, that lives paycheck to paycheck.
And the hard thing is that we all think, well, isn't that government's job? Maybe. I guess my question to everyone is, isn't it everyone's job? Or my statement, isn't it everyone's job? Mm-hmm. So to take a look at some of the realities, at my organization, we do studies each year to understand the impact in the partnership between biotech and pharma and the nonprofit organizations and community-based organizations that are out there with patients. Included in this are also insurance companies, because we know they're calling themselves patient advocates now too. Same thing with specialty pharmacies, PBMs, everyone's an advocate. It's a great word. Well, what's the realities? And you can see here, these are the top 10 organizations when you think about impact in health equity. Now, it's great to see your name on that chart. Johnson & Johnson, Sanofi, Bristol Myers, the list goes on. The interesting thing is if I was to show you the community perception before you saw the reality, the perception is that Pfizer is doing the most. But in reality, when we get in to understand the actual work being done in the community across those 9 different areas of social determinants of health, it doesn't live up to the perception. The reality is what's the patient's perception, not the general community, okay? But I will also really have to help you see that graph. The highest score there is a 3.76 out of 7. So great job at leading, still have a lot of work to do, right? But as we ask these organizations, what are the key issues affecting your patient population? I'll draw your eyes to the bottom of the slide there. Social support networks and individual education. How do we help create the space that patients can, as Matt Zachary had said earlier this morning, KSE, no stuff exists. Yes, I changed his word. But you also have to recognize that there are plenty of systemic barriers to equity that are at play. Is there something that we can do as a pharma or biotech company to engage in that space? Potentially. If you understand the realities of the population that you serve, yeah. From a policy and governance perspective as well, we see the word ESG, or the acronym ESG, thrown out a lot. I'll be the first to go to war to say that ESG is not advocacy. Advocacy is advocacy. ESG now just wants to encapsulate it. Okay? But there's a lot that the community needs. The great part about this chart is when we separate it by each of the 23 different disease states that we look at, as you might imagine, the data swings quite a bit. So food security being one of the highest ones when it comes to diabetes. Not a surprise. But at the same time, that's why we do this research. We want to understand what is the impact within the community that you serve. One of the big issues, though, that we see is that, yeah, 75% of organizations claim that social determinants of health have a major impact on the patient population that we serve. Great. It's great that they recognize it, great that they want to do something about it. The problem is this: 57% of organizations do not have funding or resources available focused directly on social determinants of health within their disease state. If we go back through COVID, anyone in the nonprofit world, you know what COVID did to your organization. And we lost a lot of people, and we lost a lot of funding. But with that also comes the lack of being able to do the actual groundwork necessary to address these issues. That's where we can come alongside them as pharma and biotech to aid them. And then, of course, health literacy. This is an ever-swaying chart. Again, if you look at this, you see 5th grade and 8th grade or above as the top 2, heavily influenced by oncology and rare disease. The rarer the disease, the higher the health literacy. If you have to take 7.5 years to get a diagnosis, you're probably going to do some pretty darn intense research. But the more chronic the condition, COPD, asthma, cardiovascular disease, you fall towards that second grade reading level. So we have to understand that, but at the same time recognize that it's not, let's say your organization set it at 5th grade for your materials. Is it 5th grade in the community, or is it 5th grade within our organization? Right? Big difference.
Yes.
And who's our sounding board? Are we pulling patients in? Better yet, who do we view as our KOL? Physicians or patients? We'd hope it would be patients, but we know that's not the case everywhere. And we see, of course, as you might imagine, this is perceived to be a massive opportunity by advocates, professional societies, and the community-based organizations for healthcare organizations to focus on. They want you to help them and help their health system. We heard in the prior presentation about healthcare navigation. How do we help patients understand all the different touch points they could have or should have? How do we help them build both a care team and a support team? Two very different things, both necessary. And technology continues to be a gap. I live in South Carolina. The low country is very different than the high country, right? And technology access is just one component. Technology utilization is a whole separate ballgame. And I heard someone in the last session talk about everyone's aging, but we know there's a group that just, no matter how much support we give them, they need somebody with them to use the tool, right? So I want to talk about how we tackle it, Austin, and how your organization at the Medi has taken on trying to attempt to handle these issues with community-based organizations.
Sure. So our organization, the Medi Community Resource Center, leverages the power of technology combined with people power to connect people to free and reduced cost services in their community. We believe that in doing this, we're empowering patients and their families to take their care into their own hand because it's available 24/7, 365. There's no wrong time. There's no closed door. When they want access and want to be able to find resources in their area, they can always find it. We think that when we do this, we help them uncover when they have the thing behind the thing. When there are these SDOH barriers, then we again connect them to those resources, providing a platform and a way for there to be closed loop referrals and reduce the number of people who fall through the gaps. And then we want to make sure that these people are supported holistically. When we say holistically, really what we're trying to say is we want folks, again, to feel like, hey, I get to play a part in my own care, that I don't have to just show up and receive information, this is what you need to do, but that I can participate in my healthcare journey and the things that are most meaningful to me. When we do this, we are making sure that there's awareness, accountability, and then that there's action. Matt mentioned earlier that technology without people is pointless. This is a quotation I say all the time in this work because ultimately this isn't about technology that connects people to resources. To me, if we have technology, but patients don't know that the technology exists, well, then that technology is pointless. If these real people with real stories get on the platform, but it's not accessible, well, that's pointless. And if these same people get on this platform, they have access to these resources, but the free and reduced cost services and the CBOs that provide those services don't know that these people are trying to connect with them, they don't receive those referrals, well, then that's still pointless. So our organization is focused primarily on community engagement and what it looks like to build an ecosystem of care where folks have access, again, to these resources, and that the CBOs that provide free and reduced cost services addressing these core concerns also have the support that they need, that they can leverage the tool for the data analytics and quantitative data that it provides to them to then turn that data into dollars to support their efforts is incredibly beneficial. So this is what our platform looks like. You can type in the zip code, and then it'll say there are 3,705 programs in the zip code. There are categories: food, housing, goods, transit, healthcare services, money. And you can actually toggle over any of these categories, and it will break down all of the different services that are available within these different categories. So among these 3,705 programs, we can see that, if you go to the next slide, Matt, we'll be able to see and break down how people are actually accessing these different kinds of services. So when I say turn data into dollars, it gives CBOs the opportunity to actually have a quantifiable understanding of their impact and efficacy, where their gaps are, how people in their communities are interacting with their programs. And so, for example, this is a 90-day data assessment of how how people were using our platform over, it looks like February to May. And you can see exactly the number of searches that were done. You can see how many and what percentage of those people were looking for housing or food. You can see the number of searches for each one of those search terms. And then it will say exactly where those people were located. And then that helps us identify and understand what's happening in our community. What are the gaps that are happening in our communities and among our populations, and then have ways to go, all right, well, this is how we can remove the thing behind the thing. This is how we can work systemically in order to change these barriers.
Yep. Now, Austin, I know maybe not everyone is familiar with CBOs.
Sure.
But as you think about the ability to partner with them, where do you see them filling the need for patients?
Sure. So CBOs are community-based organizations. They are hospitals. They are nonprofits. They are the folks who are in the weeds with the people, providing the services alongside you, of course. And ultimately, these CBOs, I got into the nonprofit sector because I had a woman, during my time specifically as Mrs. America, I was meeting all of these incredible people who were doing this incredible work. And I was like, oh my goodness, if this organization connected with this organization, they together could do this. And she said to me, Austin, that all sounds great, but nonprofits don't play nice together. We're all competing for funds, we're competing for resources. And I have now spent my career dedicating my life to believing that that's hogwash. Why? Because if we actually work collaboratively, if we became an ecosystem of care, if we built a safety net of care in our communities, we can actually remove these barriers. If we keep believing the lie, in my opinion, that we are competing against each other, then we work in our silos and we don't remove these barriers. To me, CBOs are an integral part of our advocacy journey in making sure that people in our communities have access to the things that are most important to them.
Fantastic. Now, John, I know that you've run programs before. Mm-hmm. You ran advocacy teams. Help us understand how you navigate to find solutions.
Well, and I think, there are a lot of common things. We can go through this quickly in the interest of time, but while there is different and it fluctuates by disease area, one of the common things we found is, they receive underserved populations, and it's not just skin color, it's all those things that you had listed on the other slide, consistently receive a lower standard of care. We need to understand why that is. It's any one of those social determinants of health or the other things behind the thing that Austin talked about. There are a lot of reasons why suboptimal choices are made. Bias of the provider, both conscious and unconscious, et cetera, as well as patients don't know how, and some, whether it's a health literacy issue or whether it's a cultural issue, don't know how to ask the right questions of their healthcare provider, et cetera. And providers don't know where all these services, the 3,705 services that Austin just showed. And I think, if you go to the next slide, yeah. And this is the same steps we talked about. But in the interest of time, I'd rather close with what I'm now calling this, the 3 O's. First of all, I think we're finally getting to a point in this country where we realize that everybody has an obligation to address these health disparities. Mm-hmm. But we've got to make sure they're real, they're sustainable, and they're impactful. It's not just throwing money at clinical trial recruitment. It is, and the only way you can show that you're going to have the outcome, the impact that you need, is to measure through outcomes. And then if you have those outcomes and make those things measured and sustainable, it's an opportunity, not just for opportunity for impacting the lives of so many people, but, oh, by the way, also an opportunity to have more people using more drugs if you work for a pharma biotech company. I want to go back. My last point on this is the obligation. You know, as we started working with this, and you know, for those of you who were in Matt Zachary's presentation this morning, no stuff exists. If you run, patient hotlines or benefit verification or patient assistance programs, or if you're part of a nonprofit that has an interaction with patients, the people you work with and work for you may be the only other human voices that patients come in contact with except for their provider. So do you not have an obligation to make your teams aware of all the availability of the services, because you may be the only one who can steer them toward it? So you need to invest in training and awareness and education to make, as a pharma company, I would say the obligation to have those patient-facing, patient-interacting people aware of all the services available and willing to know how to communicate them in a way that is culturally impactful.
So with that, we'll take any questions that you all may have. We appreciate you for your attendance.
I heard you talk about areas that are resource poor and working in different communities. So what is your outreach tactics for those places like, let's say, Beckley, West Virginia, or rural Georgia? I live in South Carolina, so places like that you have maybe one infusion center or like one doctor with a radius of 100, miles between patients. What is your outreach process for that?
I would say by leveraging the tool, our goal is that when there are these things that we can't control, like we can't, build an infusion center, but what we can do is we can do our best to provide transportation services or connect people to transportation services that will help them have access that they need. We can do our best to connect people to resources that provide financial support. An example of this is we have a program currently running in Baltimore through Johns Hopkins, and one of our CBO partners, she gets on Instagram Live, and people will tell her what they're looking for within their zip code. She will use our tool and say, hey, here is a resource available in your zip code. Here's how you get in contact with them. And then they're able to go and take advantage of those resources that are available. While she was doing this happened about a month ago, she stumbled across a grant. Her son has a lot of health challenges, and this grant would help her pay for her own medical bills. So she applied for this grant that she stumbled upon while looking for resources with someone else, got the grant, went to her doctor's office to say, hey, I got this grant. I need you to fill out this paperwork. The receptionist at the front desk said, well, how did you find this grant? My son has these health issues. And then she said, oh, well, let me pull it up for you on the Medi. And she found that same application, the receptionist applied and also got the grant. So our goal is not to fix everything. Our goal is to equip people to be empowered to say, hey, I know a place where we can look for these resources and be connected to them. And then make sure that when those people are reaching out to those resources, we have supported community-based organizations wherever we have a footprint so that they have access to the tool, that they can leverage the tool for their own purposes, and then in addition to that, serve these people and get them the help they need.
And I would say it's a two-way street. Austin, since Matt has introduced Austin to us, and we've been now connecting with our clients, pharmaceutical companies, infusion companies, whatever, it's a two-way street. Austin very eloquently talked about how do you get patients to the care, but the other one is how, using the data of the Medi, how do we find out where the care gaps are and how do we get the care to the patients? Whether it's taking an RV with infusion chairs to a church picnic or
Yes.
whatever. Those kinds of things that, are non-conventional, non-traditional, but very potentially impactful.
People power is the short answer.
So I work for a pharmacy, and we're part of a nonprofit organization. I had a patient call a couple weeks ago, and this happens often. He wanted his medication processed right away, but so I talked to the technician talked to the case manager. A referral had been made to the health department for him to renew his benefits, which he didn't do, right? So he knew this when he called. And so I may or may not have gone on a rant in a meeting about the amount of time that we spend on people like that, as opposed to helping the people who are adherent. So my question is, have you developed or have you thought about a tool that maybe on intake for patients, you are talking about what the expectations are, what their barriers might be, so that we can figure out who needs, I don't want to say deserves, there's probably a better word, but who we should allocate that extra time and manpower to versus who needs to sort of contact us when they're ready?
I would say that I was just at the NPACE conference yesterday for NPs and PAs. It's a dialogue that's just beginning. I'm sure the PAs and NPs aren't happy that now social determinants of health are being thrown on them. But the questions and how to empathetically ask them are beginning. How to follow through and follow up comes down to that measurement component. But the frustration is going to remain until we can better drive health literacy from a younger age.
Just take the last two questions.
Yeah.
Thank you both for their presentation. One question I had, as we're talking about digital tools and availability, what we also have to address is the digital divide that happens within the older population and them needing access, and also internet barriers. So with the great resources that you have that's available online, how are you thinking about that or addressing those concerns?
Yes, I think that raises excellent points because, again, technology without people is pointless. So if we have this tool but no one can access it, then what do you do with it? One of the key ways that we have overcome this is, again, by leveraging the power of people. So our goal is that the more people who know about the platform, who are equipped and able to then support somebody who maybe is in a digital desert or doesn't have access because of electricity, for example, then, if when they are working with their nurse at their doctor's office, if they can say, hey, let me actually fill out this referral for you right now. That's how we create a closed loop referral system, so that that person immediately has that referral. They receive the information that they need. It can be printed out for them. They can take it with them that day. And at the same time, that there can be an electronic referral. The information is immediately sent to the provider. The person who is receiving the referral, the patient, also has access to it, and immediately that part is done. So the goal is, number one, to make sure that people know about it and that we are creating a culture where people are willing to help people gain access when they have these barriers. And then secondarily, to ensure that when people are helping them, that the referral is a closed loop referral, that the CBO that is receiving the referral already has all the information that they need, and that patient also has the information that they need. And one last thing, kind of drawing from the question about whether or not that these people deserve the help or not, one of the things that always piques my interest is, why does the person not want the help? They showed up for this appointment. They knew something was wrong. And based on what I see in my work is that often it's because something has happened that made them believe that it didn't matter if they went to the doctor or they went to take advantage of that resource. And that, again, is another example of the thing behind the thing. So creating a culture and an ecosystem that is a safety net of care is an integral part of our community engagement model. It leverages the power of people and relationships and relational capital in order to get the work done.
That we have.
All right.
Thank
Thank you all very much.
Thank you.